Hello, everybody. Welcome to our Insight NAPSAD webinar for the 5th of May. And today is actually World Maternal Mental Health Day. That's a nice little segue into talking about sleep deprivation and mental health, I think. But welcome, everyone. My name's Irene Francisco, and I am happy to be hosting today for Insight. And we have a really excellent presentation happening in just a moment, but first I'd like to acknowledge the traditional owners of the lands on which we're meeting today. I'm standing here in Brisbane, Meanjin on Turrbal and Yagara land, and I pay my respects to elders past, present and emerging. So thank you and welcome to our First Nations people who are also joining us across the nation. And I would also like to acknowledge those people with a lived experience of substance use, mental health issues, and those affected by suicide, and recognising the immense learning that they provide for us as professionals coming into this field. Welcome anyone with lived experience who's joining us today, and their carers and loved ones who support them on their journey. I would like to introduce Sara Winter. Sara, hopefully you're there and ready to. Thank you, Sara. Welcome. Dr. Sara Winter is a clinical psychologist who specialises in sleep. She works at the Prince Charles Hospital and Metro North Hospital and Health Service, and also in Greenslopes Private Hospital. Sara's got over 15 years experience with special interest in sleep disorders, and has worked across both private and public sectors, as well as in the university sector. And she's going to talk to us about sleep. Just a reminder to everyone too that you can put your questions in the chat as Sara is presenting, and we will have time for questions at the end of the presentation. So over to you, Sara.
Thank you. Hopefully I can, good, all right. I want to thank you so much for inviting me to talk on this topic. It's something I feel enormously passionate about as a clinical psychologist, and particularly that interplay with mental health. So hopefully, this will give you a good foundation into the role of sleep, mental health, and what we can do about it clinically. It's quite hard to condense everything into 1 hour, so I hope this is a reasonable foundational place to start. So as a bit of an outline, I'd like to talk, what is sleep generally, what are the consequences of sleep disturbance, and I'll be talking more on a chronic basis, of course, the interplay with mental health challenges, and then most importantly, how can we assess it and do something about it? I did want to acknowledge Dr. Claire Ellender from the PA. So some of her slides are ones from presentations that we have done together. So I just wanted to let you know that there's kind of just to reference her there. Right. I guess in terms of defining sleep, it's an experiential, physiological, reversible and time-based phenomena. And we go through different cycles of sleep reasonably reliably. We have stage 1 and stage 2, which is our light sleep. And in fact, we spend most of the time in light sleep, which is an important part of psychoeducation for people who are having sleep disturbance. In light sleep, there will be some awareness. There'll be some awareness of the environment and body and all of that sort of thing. And when there's been a chronic sleep disturbance, often people will come naturally to a light stage of sleep, become aroused about that and pull themselves out of it. Then we've got these 2 deeper stages of sleep, stage 3 and 4. This is a bit more like we imagine sleep should be. You're not aware really anymore in a deep sleep. This is where a lot of the restorative function of sleep occurs also. And then we've got the 5th stage of sleep, which is REM, or rapid eye movement sleep. So our brain gets really active again. Our major muscles are switched off, so we don't act out our dreams, except in the case of REM sleep behaviour disorder. And we believe that this is where a lot of emotion memory consolidation occurs. So if we think about the way in which we would typically cycle through sleep, normally go light sleep down into deep sleep. We don't stay there all that long. We come back up and then have our first period of dreaming or REM sleep. And we cycle through like that every 90 minutes or so. there's, on average 7 to 8 hours for a typical healthy young adult. We use up most of our deep sleep first, because there's more of a sleep drive, as we're going into bed. Later on, we spend more time in light sleep and a bit more time in REM sleep. And because later on in the sleep cycle, we're in these sort of lighter stages of sleep, that's when we might be aware of some brief awakenings from sleep. Our sleep changes as we age as well. So we need slightly less sleep as we age, and we spend a bit more time in light sleep. And for that reason, there tends to be some natural, a few more brief awakenings from sleep. So I think, just having a bit of a foundation into normal sleep physiology is quite important in terms of managing sleep. It often will decatastrophize for many people when they're concerned, oh no, I'm waking, or, there's some awareness, and being able to normalize that to some extent. Now, sleep disorders are common and costly. You might have noticed in the media for the last week or so, there's been quite a bit of talk about sleep and implications of sleep, because the Sleep Health Foundation has just released a kind of an updated report. So it's the Rise and Shine report looking at the social and economic costs. So I've put the link down there at the bottom of this slide. The data from this slide comes from the Access Economics report in 2011, which is kind of, really just been recently updated. But in 2010, about, just under 10% of the population had a sleep disorder, which is quite common. Obstructive sleep apnea being the most common, then insomnia and restless legs syndrome. So sleep difficulties is enormously common, and from a clinical psychology perspective, depression, anxiety, and insomnia would be, kind of right up there in terms of prevalence and incidence. We know that sleep is one determinant of health, and if we think of it as a foundation of health, diet, sleep, and exercise, and has some links, although through some complicated mediating kind of mechanisms at times, but with sort of some key aspects of our health and mental health. The healthcare cost of sleep disorders in 2010 was estimated at 118 million. But when we take into account the broader economic cost, in addition to health, things like absenteeism and mental health, car accidents, and etc., the cost to society of sleep difficulties that haven't been managed is enormous, really huge. Now, I'd like to talk to you a little bit about insomnia. I don't want to spend a lot of time going through diagnostic criteria, because this is something that you can look up. But I guess from a DSM and ICD perspective, we would diagnose insomnia with greater than one of these symptoms occurring more than 3 times a week for greater than 3 months. And that is associated with impairment or distress in these different domains. So for this, I guess at any time, any of us could kind of meet criteria for an acute insomnia. But I guess I'm talking more about those people where the difficulty persists over a longer period of time. I didn't actually know that it's Women's and Mental Health Day today, but I guess I just did want to specifically talk about women and sleep. I think, sometimes that's underrepresented in terms of the significance of sleep and women's health. We know that women are more likely to experience insomnia. Women, there's a lower incidence of sleep apnea in women, but also it's probably underdiagnosed as well. There is a higher incidence of insomnia post-menopausally, and we know that it's a key determinant of women's health, broader than kind of, everyday health. So in terms of, from a mental health perspective, things like postpartum depression, that menopause transition, and etc. Cognitive behaviour therapy is the gold standard evidence-based treatment for insomnia. And, this recommendation is, pretty ubiquitous across all kind of, all over the world. The American College of Physicians kind of put this particular statement out in terms of recommendation. CBT-I is the first line initial treatment. They've got sort of a secondary recommendation that pharmacotherapy may be considered where CBT-I is unsuccessful or for a very good reason not applicable. But certainly the strength of that recommendation is much lower than the recommendation one. This is certainly backed up by our primary Australian bodies as well, in the Australian Sleep Association as well as the American Academy of Sleep Medicine. So it's certainly not disputed from an evidence-based standpoint and from a recommendations standpoint that CBT-I is the way to go in treating insomnia. I guess from an Australian perspective, if we look at what happens actually in clinical practice, this study looked at kind of management and referrals for GPs. And what they found was that there was quite a high incidence of people describing insomnia and sleep difficulties attending their GP. Of those people who attended, 90% were prescribed some sort of pharmacotherapy. 20% of people were given some non-pharmacological advice, the majority of which was sort of standard sleep hygiene, which, is certainly better than nothing, absolutely. Onward referral to either a psychologist, CBT-I, or a sleep physician happened around 1% of the time. So I guess, the path that people follow in terms of being managed for their sleep doesn't kind of map with what the recommendations are and what the evidence base says. Sleep management is certainly a multidisciplinary affair. So certainly GPs and physicians and medical team is important. Psychological intervention for many sleep disorders that I'll go through is certainly indicated. There may or may not be need for a sleep study to actually map the sleep physiology of an individual person. And there may be prescriptions either for medication or for devices like continuous positive air pressure for sleep apnea or mandibular splint and so on. So certainly psychology plays an important role in this multidisciplinary perspective. Just wanted to reflect on the overlap that we see across many mental health conditions and sleep. And I guess if nothing else, what I'd like to convince you of by the end of this talk is that, for too long, insomnia being seen as sort of secondary to other health or mental health challenges and treated as such. That, if we can manage the depression, then the sleep's going to improve. If we can manage the anxiety, sleep will improve. And to some extent, that's true. However, we do know that insomnia is a primary, often precipitant and a perpetuating factor in many of these health conditions as well. So, and in fact, treating the insomnia as a first port of call or as a priority is actually going to do a lot of hard work in terms of managing these other conditions. So it's well established that insomnia is a predictor of mental disorders. Certainly things like depression, anxiety, bipolar disorder, and kind of severity and schizophrenia, which I'll talk more to. And I wanted to take you through this study by Blom's group, looking at the way in which we manage comorbid conditions and the role that sleep plays in that. So in this study, they randomised people with a comorbid depression and anxiety to CBT-I or CBT for depression and assessed their outcomes. So people were given an insomnia severity index, which is, I'd recommend that if you're going to add a clinical tool for measuring sleep, it's a really excellent one and sort of helps with diagnostic clarity, as well as a mood measure. Now, what they found is that CBT-I, cognitive behaviour therapy for insomnia, certainly improves insomnia symptoms, which is not surprising, and it's clinically significant. It also improves mood symptoms, so it produces clinically reliable and clinically significant change in depression symptoms. If we look at the case though with mood symptoms, the CBT-I will improve the symptoms of depression, as will CBT for depression. But CBT for depression doesn't necessarily, certainly in a long-term perspective, improve the symptoms of insomnia. The challenge then is, with the insomnia symptoms still being significant, that then acts as a risk for relapse of the mood disorder. So the take-home message here is that CBT-I will lift both the symptoms of depression and insomnia, and will then prevent relapse of both of those disorders. CBT for depression will improve the symptoms of depression, not so much for the insomnia symptoms, and then there's a higher risk for relapse of the depression. When we look at the evidence base for young adults as well, this is a sort of a neat systematic review and meta-analysis that kind of backs this up in the younger populations as well. So when they looked at psychological interventions for improving sleep, specifically for CBT-I, with the inclusion of secondary outcomes, the symptoms of depression and anxiety as being measured in addition to that, there was a moderate effect of all interventions. But when they looked at the subgroup analyses there, cognitive behaviour therapy for insomnia certainly improved sleep, but also did improve symptoms of anxiety and depression. Again, there were sort of, moderate effect sizes there. When we look at the literature around sleep disorders and the interplay with mental health, the literature predominantly focuses on major depression, bipolar disorder, and schizophrenia. And I guess, broadly speaking, CBT-I is effective in treating insomnia in these populations. I wanted to take you through a standard CBT-I intervention and then some modifications that you might consider for people who have complex mental health conditions. I guess, broadly speaking, what I would suggest is that sometimes we get ourselves caught into a little bit of a muddle, thinking, there's also this comorbid condition. Do I need to treat that before this can happen? The evidence says that where there is comorbid insomnia, treating that insomnia is doable, even in the context of complex mental health challenges. And what we know is that CBT-I is an enhancer of outcomes in psychiatric care. So we know people tend to respond better to medications and often need lower medication dose once the sleep is regulated and managed effectively, more likely to adhere to treatment. There's a reduced risk of relapse of other mental health conditions, severity of symptoms, physical health quality of life, as well as kind of regulating 24-hour routines and rhythms. So people tend to have kind of a more richful and meaningful life if they're getting a better quality sleep. I wanted to talk you through specifically some of the literature around schizophrenia and sleep. So as it relates to sleep disturbance with schizophrenia, there's three main risks for us to consider. A significant sleep disturbance is linked to worsening psychiatric symptoms. There is a high incidence of sleep disorders, especially obstructive sleep apnea in this population, and probably the mechanism there is through obesity, with many of the antipsychotics kind of producing weight gain. We know that quality of life is rated lower where there is a concurrent sleep disturbance with people who have a diagnosis of schizophrenia. We know that insomnia is a risk factor for the development of mood disorders and psychosis, and very often a severe episode of insomnia can be seen in that prodromal phase of the illness, and significant circadian rhythm disturbance is common. So people are just sort of sleeping all around the clock and, you know, in very patchy ways. In schizophrenia, we think there's a big link there with the dopamine symptoms, the dopamine system. So overactivity of dopamine receptors in the striatum is associated with the positive symptoms of schizophrenia, which might result in increased wakefulness, which then increases the likelihood of insomnia. Treatment adherence is a problem, and we know that abrupt cessation of antipsychotics is often associated with a deterioration in sleep quality. I guess the other thing to consider with schizophrenia is that many of the medications will produce some symptoms that can mimic things like restless leg syndrome, periodic limb movement disorder, and so on. So, you know, exploring the mechanisms of the sleep disturbance, what might be some of the causative factors there, is kind of important in this population. Just want to talk to you briefly about obstructive sleep apnea. So my PhD was on treatment adherence to continuous positive airway pressure and obstructive sleep apnea. But basically, in sleep apnea, the muscles of the upper airway, you know, get a bit floppy during sleep, and so there's either partial or full obstruction of the airway repeatedly during the night, which leads to sleep fragmentation, but also leads to kind of brief periods of hypoxia repeatedly during the night. So sleep apnea is certainly a problem and has kind of wide-reaching implications, and the gold standard evidence-based treatment for that is continuous positive airway pressure therapy. From a psychological standpoint, it's very common that I would help with managing people who have a comorbid insomnia, so that insomnia then doesn't prevent their kind of acceptance and uptake with the device, and also sort of assisting with things like panic and habituation to the mask, as well as motivational interviewing, which is sort of the key part of my PhD. So therapies for obstructive sleep apnea are largely behavioural, in addition to CPAP or splints in a subset of people with a milder version of the condition. So as it relates to bipolar disorder and sleep, so we know that sleep plays a really important role in mood and emotion regulation, and that sleep disturbance is a key part of the diagnostic criteria for for bipolar disorder. Things like hypersomnia, daytime sleepiness, and the difficulty with sleep, insomnia, is often seen in manic episodes. 70% of people do report ongoing difficulties with their sleep, even when there's sort of a lull in the symptoms of the bipolar disorder. There's a higher risk of polypharmacy, hypnotic use, and substance misuse in this condition, and often hypnotics, sedatives are prescribed to people who have a sleep difficulty, which has sort of other consequences. Now, phase difficulties are really common. Sleep phase issues are really common in bipolar disorder. So a delayed sleep phase in particular is present in around 10% of these people who have a sleep disturbance. So a phase being the timing of when the sleep tends to occur for the individual. So a delayed sleep phase is a later bedtime and a later wake time, which becomes a problem if, you know, they need to be up of a morning to go to work and, or, you know, other meaningful activities. We know that the sleep disturbance is linked with recurrence of mood episodes, and that if we treat the sleep or the circadian disturbance, that also targets the, you know, many of the symptoms of bipolar disorder. So that's, you know, rather than sleep being seen as sort of a consequence, I would argue it being seen as kind of a primary driver for what's going on in many conditions, and from that perspective, actually a priority in terms of management. Now, CBT-I, I'm just not sure to what extent kind of the attendees have any kind of experience or knowledge around this. So forgive me if I'm kind of preaching to the converted a bit here, but I did want to give you a bit of a foundation of what CBT-I looks like and some of the modifications that I might use with kind of different comorbid presentations. So the key elements of CBT-I is sleep restriction. And of all the elements of CBT-I, we know that sleep restriction is the single most effective element. It's also the hardest element, but it is, you know, the most important one. Sleep compression is something I'll talk to you about though, where sleep restriction might not be indicated. Stimulus control, the association of the bed with sleep and low arousal. Cognitive restructuring, arousal management through things like relaxation. Sleep hygiene, and mindfulness as kind of more recently being quite consistently incorporated with in CBT-I protocols, particularly for those individuals who are ruminative. So we know that the cognitive restructuring is quite helpful for people who have lots of anxious thoughts about getting to sleep and maintaining sleep. It's also an important element in relapse prevention we've found after CBT-I. Is that cognitive restructuring then helps them to kind of stay on track even when they have sort of acute difficulties with sleep. Mindfulness is really good for those who they might not particularly be thinking about sleep, but they might just have a busy mind. Now, if we think about the key aspects of insomnia and the role that CBT-I plays in targeting each of these. So it certainly targets the dysfunctional cognitions or unhelpful cognitions about sleep, maladaptive habits that might develop around sleep, like spending too much time in bed, perhaps napping, other things that we know kind of are likely to associate the bed with wakefulness rather than sleep. Manages arousal and will improve many of the consequences of the sleep disturbance. Now, from a stepped care perspective, I guess I just want to say there's different layers of intensity of intervention there. So at the bottom layer there being kind of self-guided, self-help ways of managing sleep. And if nothing else, that would be a good place to start, to send someone home with some CBT-I bed restriction and stimulus control information, or linking them to an online CBT-I program. And then there's increasing layers, group and individual interventions. And then I would tend to see people more at that sort of top end where they're, you know, they're quite complex and needing kind of quite tailored and specific intervention. I guess my point here is that something is better than nothing. If you can't deliver an entire CBT-I intervention, we can kind of get them linked in and can get them started with some of the effective elements of CBT-I. There are lots of internet-based options. The Sydney Sleep Centre, Mindful Way and This Way Up being the Australian versions of online CBT-I programs. There's also Somrest and Sleepio. I really like Sleepio. It comes out of Glasgow and it's quite neat. So there's an avatar called the Prof who delivers your intervention for you, and it actually links the clinician to it, so you get sort of the updates and the information about how the client is going through that program. CBT-I Coach that comes out of Stanford. And of course, we've got our typical sort of relaxation, mindfulness, arousal management apps as well. So again, if managing arousal is kind of one of the key things that you can do, then that's a good place to start. If you're interested in kind of a comprehensive CBT-I protocol, these are two places that I'd kind of consider you to think about, sort of having a copy of this at your clinic or in your own sort of personal resources. So there's Michael Perlis's group, Behavioural Treatments for Sleep Disorders, and as well as this sort of session by session guide, CBT treatment for insomnia. Now, in terms of assessment, standard clinical interview, of course, is important. When I am working with a person with sleep difficulties, I would send them away with a sleep diary, and I'll show you the one that I use. They may have sleep study PSG data that might kind of inform things for you, but there's been not many people with a sort of a primary insomnia will be sent for a sleep study anymore. So that might not always be available. Certainly if they've been diagnosed with sleep apnea, there will have been a sleep study that you perhaps can access. Actigraphy can help to measure kind of sleep-wake patterns. And then there's some questionnaires there. In my typical clinical kind of toolkit is the Insomnia Severity Index, the DAS, and a quality of life measure like the ORS. But I guess what I would recommend is that, as a matter of course, with just about everyone that you see, kind of slipping in an Insomnia Severity Index. It's only kind of got 7 items. It's really brief, and will give you a bit of a handle of any sleep difficulties arising. Now, this is the American Academy of Sleep Medicine Sleep Diary, and this is a common one that's given, and it's quite fine. It's not the one that I use, but not because, you know, for any reason other than, you know, they're all good. So that's an option. This one's available online, and I've put the link there for you. I like to use the one that comes out of Adelaide, and if you'd like, I can always send you, you know, a link. But what it does is sort of in a more visual format, kind of track the sleep pattern. Also asks a lot of information about when the person eats, when they exercise, caffeine, how frequently that's happening. And I feel that that's really relevant, particularly, you know, when I talk later about bipolar disorder and other kind of conditions. Kind of sometimes we spend a lot of time thinking about the nighttime part, but getting the biological rhythms during the day, it can be equally important. So sleep restriction. I wanted to talk you through this. As I said, this is the single most effective component of CBT-I. So if I've only got a brief period of time with someone, I will get onto this as a matter of priority above anything else. It's nice to do the entire protocol, but sleep restriction is your single most effective part. The idea is to increase sleep drive and to increase the association of the bed for sleep. So what we do is use a sleep diary to calculate what's called the sleep efficiency. So the percentage of time that the person that they think they're asleep as a proportion of the total amount of time that they're in bed. And what we want is for that sleep efficiency to be about 85% or more. So 85% of the time they're in bed, they think they're asleep. So that allows for, you know, a little bit of time just to get off to sleep. That allows for some brief awakenings to get up and go to the toilet or kick off the blanket or have a sip of water and so on. We're not aiming for, you know, 100% sleep efficiency. And in fact, that's not normal and can be a problem in and of itself. There will be a little, you know, brief awakenings and a little bit of awareness along the way. So 85% or more. What we do is, based on that sleep diary, restrict the amount of time that they're in bed closer to how much sleep they think they're getting at the moment. So let's say on average they think they're getting about 6 hours, but they're 9 hours in bed. The sleep efficiency is quite low. The association of the bed for sleep is quite low, and they're associating that bed with lots of arousal. So I'd restrict their time in bed to about sort of 6.5 hours, closer to that window. And then as that sleep efficiency improves, as that time in bed is more associated with sleep, then we gently increase that time in bed by about half an hour a week. So we use this algorithm. You know, if it's the sleep efficiency is 85% or more, I might increase the time in bed, particularly if they're saying I'm sleeping well in that window and I'm still sleeping, then I'd add extra time. If it's under 85%, I'd probably reduce that time in bed a bit more. But usually for most people, if they stick to this, within a week, that sleep efficiency's up. It's unusual that it might take 2 weeks. So we just gently titrate it back out. Every time that sleep efficiency is over 85% and they're still sleepy, we increase it back out until we kind of reach that point where they say, I'm feeling good. or that sleep efficiency starts to drop back down, which tells us, okay, we've gone a bit too far. We need to bring it back to whatever the last bit was. What this does is create a mild sleep deprived state, so people will feel really sleepy. We're building that sleep drive so that by the time they go to bed, they're quite ready to sleep. And then that sleep drive helps them to kind of flow through those stages of sleep, you know, more seamlessly. We never restrict under 5 hours. The research tells us that as long as we're not restricting under 5 hours, you know, the risk of car accidents and kind of stuff related to this brief period of sleep restriction, you know, isn't an issue. I always would provide some precautions for people though. I'd say cautious about driving, don't operate heavy machinery, so, you know, just while we're doing the kind of most intense part of the sleep restriction. People really don't like sleep restrictions. I like this the least, but it is the single most effective part. And there's few things in life that I can kind of with confidence say will work, but this is one of those things. If for, you know, except in very rare cases, say if you stick to this, it will work. You'll expect the first couple of nights to be pretty rough. You know, that conditioning of the bed for arousal, and there hasn't been a good build up of that sort of sleep pressure yet. The first couple of nights, that's usually when people chuck the towel in. But if they can stick through that last bit, usually by the end of that first week, they are sleeping pretty consistently in that sleep window, and you can start to increase it back out. So how, apologies, my screen is popped out. There we go. Right, so how it works. Sleep restriction is so powerful in that it targets all these elements of the precipitating and perpetuating factors of insomnia. So it helps to regulate that circadian rhythm because we've got a fairly consistent sleep-wake window. We're building sleep drive by being out of bed. The longer we're out of bed, the more need we have for sleep. Because that sleep drive is high, it's going to reduce arousal because essentially it will take over. The body doesn't have an opportunity to wind up in bed because that sleep drive will help them get off to sleep. So it helps to recondition the bed for sleep and lower arousal. It kind of helps with that sort of conditioning of the bed for sleep. It will target many of the anxious cognitions about sleep also through this behavioural experiment. It's hard to kind of persist with the belief that I can't sleep when I'm sleeping. It's hard to persist with the belief that I must get 8 hours sleep, otherwise I can't function. When I'm doing sleep restriction, I'm getting 6 good hours sleep this week and I was able to do what I needed to at work. So it is quite powerful. It can be scary to implement sleep restriction the first couple of times as a clinician, but you know, certainly you'll be sold after kind of getting the good outcomes quite quickly with people. Stimulus control really is about other ways in which we can associate this bed with sleep and low arousal by managing kind of environmental cues. The idea is to go to bed only when sleepy rather than just because the time got to a certain part, you know, on the clock. If I'm not getting off to sleep, hopping out of bed and doing some low light, low stimulus activity, but being aware as well that when we're in a light sleep, there will be some awareness. So what I suggest to people is if you're calm, heavy, relaxed, go with it. You're probably close to or in a light sleep, just wind down further into it. But if you are certainly wide awake, this mind is busy, you're feeling agitated in any way, hop out of that bed, wind down until you feel sleepy enough and try again. We want to associate the bed with sleep and sex and, you know, very low physiological arousal. So we want to avoid doing anything that winds us up in bed. Trying to get up at the same time every day, even if you had a night where you weren't ready to get off to sleep until a bit later. Helping to try and get up to also helps with anchoring that circadian rhythm. Try to avoid napping, trying not to clock watch, and using arousal management strategies to wind down, to make sure we're not in low arousal and sleepy for going to bed. Now I wanted to talk about some of the cautions around these techniques, you know, with people who might have significant comorbidities. So particularly with bipolar and mania, acute psychosis and seizures, we know that there's some experience of mild mood elevation with CBT-I. So it can lead to some mania symptoms or some subclinical mania symptoms. So there's two main risks really to consider. So that sleep deprivation can increase the risk of mania relapse, particularly in bipolar 1 and women with bipolar disorder. And we want to titrate daytime activity levels to guard against hypermania or mania. So if we think about it, often part of what occurs in a manic episode is that people get overactive during the day. And that certainly, staying active is a technique in terms of managing sleep. I want to try to avoid sleeping during the day so I can get a better quality sleep at night. But we just want to be cautious that people then aren't overdoing and booming and busting in terms of their activity during the day. So just sort of staying active, but in, kind of a healthy way. And just really also monitoring kind of mood symptoms, see whether you need to make any adjustments to your protocol. So by way of some recommendations, depression and mania symptoms should be monitored in every session. Sleep restriction and stimulus control, you might suspend if you've got any concerns or if symptoms start to emerge. And I want to talk to you about sleep compression as an alternative to sleep restriction. So sleep compression works on the same kind of protocol. I guess it's a bit slower and gentler. So rather than restricting the time in bed in kind of, such a significant way, what you might do is just sort of bring in each end of, how much they're sleeping at the moment. So that person who's spending 9 hours in bed, you might move to 8.5 hours, see how that goes. And then you might move to 8 hours. So you kind of reverse titrating that way. So if you have any concerns about sleep restriction, sleep compression is something that will do the job for you, achieve the same outcome just through a different route. So cognitive strategy. So we want to be able to identify any misperceptions around sleep. Often people think that they're awake all night or they're misperceiving light sleep for wakefulness. But misattributions about the consequences of, that difficulty with sleeping, and often lots of catastrophic thoughts around that. And also just people who are ruminators, they might not necessarily have anxiety about sleep, but they might just have a busy mind. So typical cognitive restructuring, things like worry time can be really helpful for people who are kind of ruminative, problem solving, and mindfulness is really kind of, emerged as quite helpful as part of a CBT-I protocol for many people where there's rumination and cognitive arousal. Sleep hygiene. Now, this is the stuff that most of us already know, and it's the stuff that most people in the community would know. So when I get someone to come in and see me, they say, I've done everything already. Usually this is all the stuff that they've done, and all of this is good and helpful. So that's great, but what the research says is that it's certainly not enough to treat the full condition. So I'd recommend that you try to go beyond sleep. Certainly give the sleep hygiene education, but try to go beyond that in terms of managing that insomnia. All right, so I'll just let you have a look through the list there. It's all straightforward. Now, I did want to take you through a few protocols that where there's been, research around adjustments to CBT-I for different psychiatric populations. So this group, the University of Western Australia, Waters, Ree and Chu, developed a CBT-I protocol for those with psychosis. So it sort of incorporated the key elements of CBT-I, but with adaptions, basically. So some of the things that were sort of changed or modified for this protocol is insomnia was kind of highlighted as changeable rather than fixed. Many people have that kind of perspective that, sleep is just sort of going to be a problem forever, whereas it is something that we can modify even in the context of people with quite acute or significant psychiatric illness. Use sleep compression, as part of managing that time in bed. Motivational interviewing was incorporated to increase treatment adherence to elements of the CBT-I protocol, but also, considering things like medication and so on. Imagery rehearsal was incorporated for those where there was sort of nightmares and night terrors and things like that. And that's certainly something that I will incorporate for many people where there's a trauma element related to their the sleep disturbance. So your typical sort of trauma elements to it in addition to the CBT-I. Arousal management and grounding, incorporating social supports and resources. So considering the daytime elements rather than just the night. They simplified the sleep logs and materials so that it was sort of more user-friendly. Medication dosage and timing collaboratively with their medical health providers was considered as part of the protocol. The sessions were a bit shorter with more frequent breaks as needed. So there was some, that was sort of matched to as needed for the people. The materials was made to be a bit more interesting, larger font and that sort of thing. And I guess what I'd say about that is that yes, there's a few studies and I can send you the links if you would like to demonstrate that that was an effective protocol for improving insomnia in that condition. There has also been a protocol developed for CBT-I for bipolar disorder. And so this is Kaplan, Talavera and Harvey's group developed this CBT-I BP protocol where the aim is to improve mood, sleep and functioning. So it's sort of got broader implications, but sleep being a key element to it. So it consisted of 8 weekly sessions of up to about an hour. And in addition to kind of the standard CBT-I protocol that I kind of broadly took you through, it incorporated elements of interpersonal and social rhythm therapy, with the key part of that being to look at that daytime behaviours, making sure there wasn't overactivity during the day, linking with social support. So that's sort of, incorporated into it. Chronotherapy, which is about getting the sleep timing right. So for those who had a delayed sleep phase or an advanced sleep phase, which is the opposite, going to bed much earlier and waking much earlier, or maybe a 24-hour rhythm where they kind of sleep all around the clock, part of the intervention was helping to anchor that biological rhythm through things like light and activity. And it incorporated a motivational interviewing element to this protocol as well. Again, good evidence base around this adaptation in improving sleep, as well as those symptoms of the mood symptoms and improving quality of life and functioning. Now, I recognise I'm kind of getting tight for time now, but I did want to talk, I've mentioned that term circadian rhythm a lot, and I guess I just wanted to spend a little bit more time talking about that. There is, a few different variants of the way in which our biological clocks can get out of whack. Delayed sleep phase disorder being one of the top most common one, and then an advanced sleep phase, which is the opposite, bed early, wake early. Then we've got these irregular and non-24-hour kind of patterns that can come up. Shift work disorder, so that can develop as a consequence of working all around the clock and our body's circadian rhythm getting out of kilter, and jet lag. Now, the way in which our circadian rhythm for sleep is anchored is through light, through that pathway, through the SCN, the suprachiasmatic nucleus in the hypothalamus. It helps to sort of regulate our body's 24-hour sleep cycle. So light is your best friend in terms of anchoring that rhythm. We want to get as much light as possible at the desired wake time. We want to minimise and reduce light as much as possible kind of in those couple of hours before the desired bedtime. Parasomnias is something that I see quite often as well. And I just wanted to give a little bit of a nod to the way in which kind of these sleep disturbances can manifest. So we've got non-REM parasomnias. These are the ones that don't occur in rapid eye movement sleep. So waking, confused, sleepwalking and night terrors, sleep-related eating disorder. Then we've got REM-related parasomnias, with REM sleep behaviour disorder being that condition where people act out their dreams. That condition is rarer, but of a concern. The research indicates that people with this condition can tend to develop Parkinson's disorder later down the line. So that's something to be aware of, and to certainly send for a sleep study if you've got any concerns about that. Exploding head syndrome, sleep-related hallucinations. So there's all sorts of interesting stuff that can come up. Arousal management, imagery rescripting and imagery rehearsal are common ways in which, as well as plus or minus trauma interventions, common things that I will incorporate where there's parasomnias. So if we think about the role of psychology in managing these, we want, in terms of predisposing factors, what happens in parasomnias is there's a lack of thalamic inhibition. So the thalamus acts as sort of the gateway to kind of sensory input, and for whatever, the way I'll explain it to a client is that it kind of is a bit floppy. So information's getting through and we're kind of acting out dreams, or environmental cues are getting through, that's then leading to kind of nighttime activity. So ways in which we can manage that is through arousal management, kind of winding this nervous system down so there's less information to get through. In terms of the precipitating factors, sleep restriction, difficulty with getting enough sleep is something that can increase the likelihood of parasomnia. So we want to make sure we're getting good quality sleep, but also working towards the right quantity of sleep as well as problem solving, making sure that we're prioritising sleep as part of our sort of daily routine. And we know that stress and anxiety tends to be a perpetuating factor. It increases the likelihood of experiencing parasomnias. So managing that through intervention can increase the intensity, frequency and duration of these nighttime events. Right, so by way of a summary, I just wanted to highlight that sleep disorders are common and have a significant impact health-wise, to the economy and so on. History and assessment's really key. I think sometimes we forget to even ask about sleep or to spend much time even assessing sleep. So I would really encourage you, for everyone that you see, to ask about sleep as a minimum. CBT-I is the gold standard evidence-based treatment for insomnia and is extremely effective across multiple populations. And we know that sleep is a key determinant of health and mental health.
Awesome. Thank you so much, Sarah. That was such a fascinating presentation, and it's definitely generated lots and lots of questions. So if you're able to hang around with us and answer some of those questions, that would be fantastic. There's been a few kind of little thematic questions coming through the chat. And one was in relation, a couple of people asking in relation to trauma and sleep. And you did mention in terms of the parasomnias, the effects that that there can be in terms of particular trauma responses. So would you be able to just elaborate a little bit more around trauma and sleep, and particularly how sleep might be involved in processing trauma and the things that people might see in terms of nightmares and responses to trauma?
Yeah. So certainly trauma can be a key precipitant for the development of insomnia. But what I would say is that then managing the insomnia goes an awful long way in terms of improving the symptoms of that trauma, and will help you with trauma reprocessing and longer term intervention in that regard. So I think sometimes we get ourselves caught in that chicken and egg issue. We think, okay, until the trauma's sorted, I can't manage the sleep. It's just not true. And the reality is there's a lot we can do to regulate that sleep, which will then improve much of the distress related to the trauma. You often do still need to do trauma intervention. So I'm not suggesting that it's sort of a cure-all, but I would argue that you would find your job much easier once you've regulated that sleep. So CBT-I and that bed restriction is enormously effective in improving that sleep rhythm and reducing that arousal. So even where there's this re-experiencing and nightmares, people will have less intensity, frequency and duration of that arousal and nightmares when that sleep window is more consolidated.
Lovely. And I guess following on from that complex situation of chicken and egg, there was a couple of questions related to how sleep impacts on cognition and the ability to learn skills, and then how that drives the mood disorder, for instance, is someone feeling more anxious because they're having trouble learning, and how does that then fit in with processing, say, CBT information?
Yeah. So in terms of CBT-I, what we're doing is improving sleep quality, then aiming for quantity. So in a perfect world, you would have both. But if, in the case where there's sleep disturbance, we have to prioritize quality first, then move towards quantity. That's where we kind of increase that time in bed to get more sleep. So in terms of cognition, memory, attention, better quality sleep is actually associated with better cognition and processing and memory consolidation than a longer period of fragmented sleep. So again, as a pillar of health, sleep is right up there in terms of kind of getting the foundation right, so then you can do some additional stuff.
Lovely, thank you. Yeah, and from personal experience, I have a friend who uses the CPAP and found his anxiety reduced immensely because he was not necessarily getting more sleep, but the quality definitely improved, and that made a huge impact on his mental state. There are probably a lot of interest from people who are shift workers out there, and we've had a few questions. Would you use these same approaches or similar approaches for people who are shift workers, and how does that relate when their sleep is getting periodically disrupted?
Yeah. Shift work is such a challenge. So my broad answer is yes, these principles apply, but we've got a real circadian issue at play there too. And the reality is shift work is not great for us. So if there was a circumstance where you didn't need to do shift work, then that would be the ideal. But if you're in a circumstance or an industry where you must do shift work, I think it's really important that your employer and that industry take responsibility for understanding circadian science in terms of managing shifts and scheduling shifts. So what we know is that people respond better when shifts are more regular and when they tend to move forward around the clock. So it might be days and evenings and nights and so on, with sufficient time for recovery in between, compared to shifts that are just all over the place. So if you've got shifts that are all over the place, I'd really encourage you to, sorry, my screen's logged out on me. Speak to your employer about having a healthier schedule for managing shifts in your industry and in your workplace. Now, if we understand sort of that circadian science and assuming that shifts are being scheduled based on best practice, as best as can be managed in a difficult scenario, then you'd be thinking about making sure, assuming that you're not having any difficulty with sleep. Let's assume that you're not struggling to sleep, then you want to make sure you're getting the right quantity. So it might mean that you have to sleep a few more periods during the day so that you get adequate quantity of sleep. If it's a quality issue, that's where much of that CBT-I stuff might come into play. So we'll be using things like light and activity to help with kind of making sure wherever you're at in that circadian rhythm that we're reinforcing that in terms of activity and wake time and that sort of thing. We might put in strategic naps, which I wouldn't for kind of the standard run-of-the-mill CBT-I. I'd avoid napping to save up that sleep drive, but strategic napping might be something that we incorporate in the protocol to make sure we're kind of managing arousal and the circadian process, but without using up too much of your sleep drive to kind of getting into good sleep later on. It's very much an individualized thing. I mean, I can sort of talk about broad aspects around managing shift work, but for the people that I see who are shift workers, every single person will have a slightly different protocol that I'll develop for them based on their shifts, based on their predisposition towards sleep, if they tend to be more of an owl versus a lark, and so on. So it is a very complex, significant issue, shift work, that probably requires a whole day webinar.
Yeah, you probably get some participants for that. And there's been a few questions related to, I guess, people trying to understand their scope of practice in terms of providing sleep information, sleep referrals, at what point, and you provide that lovely triangle of the stepped care. But I guess the questions have been coming through about, what point do you refer to a GP, for instance? Can we provide information around sleep restriction, or is that something that you definitely refer to a specialist around, those sorts of things? If you could provide a bit more, I guess, structure for people around that.
Yeah. So certainly there's some online training programs for managing, for kind of learning how to do CBT-I. There's some, so Michael Perlis's group, for instance, and they were the protocols I put up. He does training based in the US for CBT-I. So there are ways to upskill in CBT-I, but I didn't put it up because I just had to prioritize in terms of my time, but there's a really neat study that they did in New Zealand, looking at GPs providing sleep restriction advice and then following people up kind of, every couple of weeks, just providing through a GP 15-minute consultation information on sleep restriction, and then having kind of a bit more frequent follow-up than you normally would with your GP, was effective in terms of improving the symptoms of insomnia. So I think certainly if you seek supervision, seek additional training if it's something that you feel kind of just not confident at all with. However, if it is effective, and there are some very good protocols that you can follow, like those ones that I put up from Michael Perlis's group. So, I guess sometimes I think we're a bit gun shy. I think it sounds worse than it is, but actually it's an extremely effective intervention. Your confidence will build, as you do it, because you'll see that it's so effective.
Lovely. And I guess a very simple question here too is those apps that you provided as well that can provide, and the online CBT-I or sleep therapies or apps, are there costs associated with those? Just thinking about clients and their finance.
Some are free, some aren't. The This Way Up one, last I heard, was free. I think it still is, and it's a good program. It has all the
combination one, isn't it? It's like you get this online stuff and you've also got interaction with a therapist. Is that right?
So it depends. So it's been, they do research protocols as part of it. So I think it also depends like what they're, if they're doing a research trial at that time where they're looking at online versus clinician delivered and that sort of thing. But This Way Up is certainly one that I would probably, if you're looking for an option where there isn't a cost, that's probably where I direct people first. But with many of those apps, often they will have a current research study that they're doing. So if you're willing to be a research participant, often you can sign up for free that way.
Lovely. And I know we're running over time, so just two more quick questions, hopefully. One is around exercise and nutrition and sleep. So it's probably not an easy one, but you did mention some aspects of diet and food. There was a few questions about people asking, even a GP recommending porridge and milk before bed. But does nutrition play a part, and also prescription of exercise, does that help in terms of sleep?
Yeah, so that's a good question. The science around diet and sleep is still, and in fact, there's trials happening around ketogenic diets and all sorts of stuff. So the science isn't totally clear there. So I think timing is probably the most important thing to consider there. You don't want to have your main meal too close to bedtime. I recommend people leave about 3 hours, because metabolism generates sort of wakefulness through heat. So it's arousing. So you want to make sure you've done most of your metabolizing prior to going to bed. If you're hungry, have something small before bed. So, and I'd recommend something like a glass of milk, or so a warm milk is an old wives' tale. It's actually true. So just have something that is for you, might be, and as long as it's not got caffeine in it, something that is sort of associated with comfort for you, takes the edge off any hunger that you might have, but you're not kind of having a big meal. Caffeine is important to consider. Caffeine has a very long half-life that often people aren't aware of. So I recommend people have their last caffeinated beverage, assuming they're, if they're kind of sleeping at a different point in that circadian rhythm, then I would adjust that recommendation. But assuming they sleep at a fairly normal window, I recommend that they keep caffeine kind of before midday, which is a huge amount of time, but that caffeine will really linger in your system. You don't want to add any additional kind of fuel to the fire, so to speak. And exercise was your other question, wasn't it? So timing is important there. So being physically active during the day is important to feel kind of physically tired, and that exercise will help burn adrenaline and cortisol, and help with kind of stress and arousal management generally. You don't want to be doing it too close to bedtime, because you don't want to be generating heat and arousal. You want to have enough time to wound back down again. And I'd be thinking about the intensity of it too. Sometimes people think, I just need to knock myself out, kind of do intense exercise. If we think about that from a biological standpoint, our ancestors, if I'm running full pelt, I'm probably running from a predator, right? So we don't want to kind of be sharing so much physical activity that my system's like, oh my God, there's something big happening here. So moderate, healthy, regular exercise is certainly very, very important in terms of health management generally, but also will help with building that sleep drive for that night.
Yeah, and I guess, as you said earlier, it's very individual how it works for each person, that sometimes their arousal systems will be very easily tipped, but other people, they'll need something to get them settled. Yeah. And lastly, I think we'll end on this one, but what is your opinion on the use of melatonin?
Oh gosh, so that's a great question. So in terms of evidence-based pharmacotherapy, in my view, I don't think I'm sort of saying anything out of turn, it's probably got the best evidence. I certainly wouldn't recommend hypnotics or benzodiazepines or anything of that nature. Melatonin's important. So CBT-I usually does the job in terms of getting our circadian rhythm right, and your body's own natural release and suppression of melatonin will fall in line with that. It will do the job. But for a subset of people, they might need supplemental melatonin. And there's two main kind of forms, I guess, to consider from this perspective. One is the tablet form, circadian, for instance, which is a longer acting form of melatonin. So it's quite good for people who have a sleep maintenance issue. So it's sort of a slower burn melatonin, which will help kind of maintain sleep. For people where it's more of a circadian rhythm issue, just kind of needing to anchor the bedtime, the liquid form of melatonin is best. It gives a high kind of dose of melatonin to help to kind of, increase your system's kind of immediate short-acting melatonin to help you get off to sleep. That's assuming you don't have sleep maintenance issue. So then you can kind of go through naturally your sleep after that's been metabolized. So I guess short answer, for majority of people, CBT-I does the job. For some people, melatonin might assist. The trouble is when they've been prescribed melatonin, they might have been prescribed the tablet when actually they probably needed the liquid, or vice versa. It's less common vice versa. Usually they get the tablet. So timing is important. Understanding the mechanisms of how it works in terms of what the particular sleep disturbance is important.